Thank you all for joining us. My name is Melissa Rosen. I am the Director of Training and Education at Sharsheret. And welcome to tonight's webinar and the 2024 Sharsheret Summit. This webinar, Cutting Edge Innovations and Treatments for Tomorrow's Cancer Care, is part of that summit, which brings together thousands of people, both virtually and in person, all across the country and honestly beyond, from October 9th through November 10th of this year. We hope you'll continue to join our national webinars on the latest hot topics in breast cancer and ovarian cancer. And there's still time actually to attend or host an in-person program or an awareness-raising event with community partners around the country. And you can learn more about that in our digital toolkit found on our summit website. Our upcoming webinars and the link to that summit website are being added to the chat below. However you choose to participate, our Sharsheret Summit is a source for the latest information on breast cancer and ovarian cancer. Before we begin, I want to take a moment to thank our Sharsheret Summit partners, AstraZeneca, Daiichi Sankyo, Merck, Novartis Oncology, Pfizer, City of Hope, AZI, Northwell Health Cancer Institute, and RMA New York of Long Island. And thank you specifically to Sherry Helfand Wiener, RMA New York, and Northwell Health Cancer Institute for their support of tonight's specific webinar. Additionally, thank you to our many summit program partners that you saw on the opening slides. Their partnership has helped make this year's summit a success. One of our lead summit sponsors, Daiichi Sankyo, has a message they would like to share with us now.
Hello, my name is Gisu Dikodes. I'm the Global Head of Advocacy and Strategic Relations at Daiichi Sankyo. On behalf of our entire team, we are honored to partner with Sharsheret year-round and be part of its national summit. Sharsheret's model to provide emotional support, educational resources, and financial assistance ensures those living with breast and ovarian cancer have the knowledge and support needed to make informed decisions about their care. This includes vital genetic testing for Jewish women and their families to understand their risk while also advocating for precision medicine treatments that could potentially alter their outcomes. Sharsheret's commitment to personalized support for those living with cancer mirrors Daiichi Sankyo's mission to contribute to the enrichment of quality of life around the world while addressing diverse medical needs. Together, we share a deep compassion for patients, and by combining our strengths, we empower those at increased genetic risk to not only manage, but thrive in their health experiences. Thank you for allowing us to be part of this essential work as we continue making a meaningful difference in the lives of those affected by cancer.
Thank you so much to all of our sponsors. Housekeeping items, then we're going to dive right in because we have a lot to get to tonight. Our webinar is being recorded and will be posted on Sharsheret's website along with the transcript. Of course, as always, participants' faces and names are not in the recording. And if you would like to remain private, you have that option to turn off your video and rename yourself, or you can call in to the webinar. Instructions on how to do that are in the chat box right now. We now have closed captioning available. To display live captions, on the bottom bar, click Captions and then Show Captions. You may have noticed that you were muted upon entering the Zoom. Please stay muted throughout the call. If you have any questions, please feel free to send them into the chat. We will try our best to answer all of them throughout the program. A reminder for our Embrace community. We invite members of that community, those facing metastatic breast cancer or advanced ovarian cancer, To stay on at the end of the webinar for an intimate breakout session with Dr. Zimmerman about treatment and biomarkers, and Bonnie Beckoff, our Director of Support Services. Let us know if you have any questions, again, here in the chat, or to send a question anonymously. Please click on the button that says Everyone, and then select Melissa Rosen Sharsheret, and your message will only be visible to me. Or just Sharsheret, I see it says, just Sharsheret. As we move into the webinar itself, I want to remind you that Sharsheret is a national not-for-profit cancer support and education organization and does not provide any medical advice or perform any medical procedures. The information provided by Sharsheret and tonight's speakers is not a substitute for medical advice or treatment for a specific medical condition. You should not use this information to diagnose or treat a health problem. As always, if you have any questions that are specific to your medical care, seek the advice of your physician or a qualified healthcare provider. Okay, we are so honored to be joined this evening by three esteemed and engaging doctors who are on the cutting edge of cancer treatment and bringing it to their patients. I will introduce each one of us as they join us on the screen. Okay, first we have with us Dr. Brittany S. Zimmerman. She's a board-certified medical oncologist specializing in the care of patients with breast and gynecologic cancers. She joined Northwell Health in 2021 as an attending physician. She's also an assistant professor at Donald and Barbara Zucker School of Medicine at Hofstra and Northwell. She brings a combination of academic training and research to her patient care approach, providing information about clinical trials and sharing advancements in evidence-based medicine. She recently expanded her practice at the Northwell Cancer Center at Greenlawn, Huntington, and opened the first breast cancer-focused clinical trials at that site. She continues to work to open additional breast and gynecologic cancer trials so that patients can have access to state-of-the-art treatment approaches close to their home. Tonight, she will be speaking about how biomarkers impact treatment. Welcome so much, Dr. Zimmerman.
Thank you so much for having me. I'll share my screen. Let me know.
You're good.
Okay. All right. So I wanted to speak today about how genomic markers guide breast cancer treatment. My name's Dr. Brittany Zimmerman. I'm a breast and gynecologic medical oncologist with Northwell, and I did my training in Manhattan at Cornell and then at Mount Sinai for internal medicine and for my fellowship in hematology and medical oncology. So when I speak to patients about a new diagnosis of breast cancer, there are two things that I typically discuss. The first is the stage of the breast cancer, and the second is the type of the breast cancer. And this will sort of set the stage for the rest of my talk. So when we talk about breast cancer stages, it can be anywhere from a stage 0, early stage DCIS, through to a stage 4 distant metastatic disease. The next important thing that we discuss is the subtype of the breast cancer. So there are 3 different receptors that can sit on the surface of a breast cancer cell: the estrogen receptor, the progesterone receptor, and the HER2 protein. If the estrogen receptor or the progesterone are positive, that's referred to as a HER2 positive, hormone positive breast cancer, which many of you may have heard of. The HER2 receptor is overexpressed in about 20% of breast cancers and was typically associated with more aggressive breast cancers, but now we have very targeted therapies for this biomarker. And a triple negative breast cancer is also a type of breast cancer that tends to grow more rapidly, and it does not express any of these 3 receptors, so it doesn't have as many targets for treatment. So what is the role of the breast medical oncologist and my team? One of the main things that we do is to prescribe hormonal therapies for hormone-positive breast cancer. We prescribe chemotherapy, immunotherapy, and targeted therapies. And then we manage any of the side effects that come with these treatments. We also manage the symptoms that are related to the underlying cancer itself, including fatigue, patients having poor appetite, all the different things that come with a cancer diagnosis. I coordinate with a multidisciplinary team and present many of my patients' cases at our tumor boards. And we work very closely with pathology, radiology, radiation oncology, breast surgery, plastic surgery. So it's really a whole team approach to every patient. I refer patients to clinical trials, and we open our own trials so that we can really look to incorporate trials that make sense with the patient population that we serve. And then there's a whole host of supportive care that we offer, including nutrition, social work, and genetics. So I'm going to do a very quick whirlwind tour through a few different scenarios where we use genomic markers or biomarkers to guide therapy for breast cancer. And this is focused really on breast cancer. Ovarian cancer would be a whole nother talk, but I'll touch on it if I can. So the first thing that I'll speak about is genomic profiling for early stage hormone-positive breast cancer. So some people may have heard about using the Oncotype recurrence score, and this is a biomarker test that we use to help decide which patients with early stage hormone-positive breast cancer can be spared chemotherapy. So we used to offer chemotherapy to all patients with hormone-positive breast cancer. We now know that if we send off this special test, which actually looks at 21 different genes within the tumor itself, that we can identify up to 85% of patients who we can actually spare chemotherapy. So this is an example of one of the reports. If the score comes back as less than 25, then those are patients where we can consider sparing chemotherapy. So in this case, if the score came back as a 32, we would know that we would want to offer that patient chemotherapy because their risk of having a recurrence in the next 9 or 10 years would be improved by over 15% by adding in the chemotherapy. So this was a huge change in how we treat hormone-positive breast cancer. And it led to exploring this further and trying to see, can we actually expand this to patients who have maybe stage 2 disease where they do have some lymph node involvement. So now we actually know that for at least postmenopausal women who have recurrent scores that come back less than 25, that we can actually spare those patients chemotherapy if they have only 1 to 3 lymph nodes which are positive. So we're able to find a huge chunk of patients who don't actually need chemotherapy and all of the side effects that come along with that. So that was sort of one of the first times that we really used biomarkers to de-escalate therapy for breast cancer. I'm going to turn now to triple-negative breast cancer. And remember how I mentioned that these are breast cancers where the cells are more rapidly dividing and don't have a lot of other markers that can be targeted. So one of the things we know now is that in addition to standard chemotherapy, which targets cells that are rapidly dividing, we can add in immunotherapy for these patients. So PD-L1 is a biomarker that can be expressed on breast cancer cells. So you can see here how the PD-L1 attaches to the PD, and this activates the body's own immune system to go after the cancer cells and kill off cancer cells. High PD-L1 expression is associated with having a greater response to treatment with immunotherapy. And PD-L1 inhibitors, which are types of immunotherapy, have been approved to treat cancers including melanoma, lung, kidney, bladder, and now, of course, breast cancer. So that has been a really exciting use of biomarkers that has really pushed the field forward for triple-negative breast cancer. We know that we can use immunotherapy for metastatic breast cancer, but we also know now that by adding in immunotherapy for patients with early stage breast cancer, we can improve the chance that by the time the patients go for surgery after they receive their chemotherapy and immunotherapy, about 60% of patients will not have any cancer remaining at the time of surgery. And that's pretty incredible. So they've done studies that show that with just chemotherapy alone, the rate of having a complete response or no tumor left at the time of surgery is about 50%, and that went up almost 14 points by adding in immunotherapy. So this has really changed the way that we approach triple-negative breast cancer. How can we use targeted therapy for advanced breast cancer? This is talking about metastatic breast cancer. I know we're kind of on a whirlwind through this. So for advanced breast cancer, we can use these biomarkers in a few different ways. So one of the things that we look at is we look for germline mutations. And those are inherited mutations that are found in all cells of the body and can be passed on to children and can increase cancer susceptibility. So that's something like a BRCA mutation, which, everyone here is probably familiar with. And those can be tested in the blood or the saliva to see if a patient has a BRCA mutation. But there are also somatic mutations, and those are acquired mutations that are only found in the tumor cells. They're not things that are typically passed on to children, but they're mutations that lead to cell growth and proliferation and can lead to cancer. So we commonly test patients both for germline mutations in the blood and somatic mutations in the tumor itself. So one of the ways that we do that is by using something called foundation testing. And there are lots of different companies which can do this. And I don't work for or have any stock in foundation medicine, but it's the one that I typically use. So I thought that they had a few figures that were kind of nice on their website. When making treatment decisions, knowledge is power. An advanced cancer diagnosis can change your life. Cancer is personal and your treatment plan should be too. So this really gets at the fundamental of using biomarkers to target our therapies. So how does this work? The foundation test is a test where you send off the tumor itself and it looks for these somatic mutations that can be found in the cancer. The liquid foundation test is a blood test, and that looks for circulating tumor DNA and any mutations that may be able to be seen circulating in the blood. So what's the difference between the mutations and biomarkers? Mutations are changes in the DNA that can influence cancer growth. And so for breast cancer specifically, some of the ones that we look for are the BRCA mutations, BRCA1 and 2, an ESR1 mutation, which may make patients stop responding to our first-line anti-estrogen therapies that we use for hormone-positive breast cancer, and PIK3CA, which is involved in cell growth. Biomarkers are certain characteristics of a cancer cell. So that's something like the PD-L1, which I had mentioned before. That's a biomarker that predicts response to immunotherapy. Targeted therapies can help stop the growth of cancer cells by targeting certain mutations. And then we know that using immunotherapy can help your body's own immune system go after the cancer cells and fight them. So this is just a quick example. This is a 31-year-old patient that I'm seeing now who has unfortunately progressed with metastatic breast cancer upon her initial presentation with bone and liver metastasis. So she was treated, she had a hormone-positive breast cancer, and she was treated with first-line anti-estrogen therapy and a CDK4/6 inhibitor. And unfortunately, after only 6 months of treatment, it was found that she was progressing on her scans. So what we did was we sent off a Foundation 1 liquid biopsy to look again for these biomarkers in the blood. And what we found, this is the actual testing, was that there was a PIK3CA mutation. And if you're a breast medical oncologist, you know that this is one of the targetable mutations for these patients. It also highlights the genes that were not found. So we didn't find any BRCA mutation or an ESR1 mutation or a HER2 mutation. So what do we do with this information? If we find out that our patient has an ESR1 mutation, we can treat them with Orserdu, which is a medication that targets that ESR1 mutation and helps make patients more susceptible to those initial medications again. If someone has a PIK3CA mutation, we can treat them with Truqap or capivasertib, and that targets that specific mutation. And if we find that they have a BRCA mutation, we can treat them with Lynparza or olaparib. So the really amazing thing is that by using this testing and finding out about these biomarkers, we can then offer these patients with advanced metastatic breast cancer 3 or more different oral targeted agents for their type of cancer. I want to quickly touch on BRCA mutations. So we know that most breast cancers are actually sporadic. but 5 to 10% can be hereditary with those germline mutations, and those include BRCA1 and BRCA2. PARP inhibitors are a certain type of oral medication which inhibit PARP, and basically that leads to double-stranded breaks and cell death or cell apoptosis. And this specifically goes towards cells that express BRCA and spares normal cells. So this has been shown to be an effective medication for metastatic breast cancer, as well as early stage high-risk BRCA mutated breast cancer. In terms of the metastatic setting, it improved the progression-free survival from 4 months to 7 months in the group that received the olaparib, and that was FDA approved for treatment in January of 2018. And then a few years later, a study came out called the Olympia trial, which looked at a year of olaparib for patients with high-risk BRCA-positive disease, and that also improved invasive disease-free survival and overall survival, and was approved by the FDA in March of 2022. So just to quickly kind of put it all together, let's say we're looking at a patient who has a triple-negative breast cancer. We don't really think of it as just one disease. We really approach it by looking more closely at the underlying mutations and biomarkers that may be present. So we know that for some patients who have PD-L1 expression, we can offer immune checkpoint inhibitors or immunotherapy. We also have these AKT inhibitors, which I mentioned. We can offer them PARP inhibitors if they have a BRCA mutation, and then a couple of other things that I didn't get to today, but we can see if they express any small little bit of HER2, and that can be targeted, as well as using antibody drug conjugates, which is a whole nother discussion in and of itself. And then the last thing that I wanted to talk about, which people may have heard about because it's heavily advertised, is something called Signatera or minimal residual disease testing. And this is something that is technically covered by Medicare for patients with stage 2 to 4 breast cancer. And what it does is, in early stage cancer, it actually looks to see if any circulating tumor DNA can be found in the bloodstream, and that can be a sign that a cancer recurrence may be looming around the corner. It usually predicts a recurrence about 10 to 12 months before a recurrence will happen. So if we go back, actually, this was an email that I got sent directly to my cell. So they're really, pushing to use this type of testing for patients with both early stage and metastatic breast cancer. The way it works is that it takes a tissue sample as well as a blood sample, and then it kind of monitors levels of the circulating tumor DNA over time. And obviously, it's ideal for the tumor DNA to be at 0, but if it starts to rise, then it may be a sign that a recurrence may happen. And if it starts to rise while you're being treated for metastatic disease, it may be a sign that the treatment needs to be changed. So if you have a negative result, no ctDNA, then that means the risk of cancer recurrence is reduced. And if you have a positive result, then that means your cancer is more likely to come back, or that your cancer treatment may want to be changed. However, I say this all with a huge caveat that most medical oncologists are not yet using this technology, and it's not really for prime time yet. And the reason is that we don't necessarily have the data that shows that using these things and finding out this information helps to change prognosis. And in some cases, it may actually lead to sort of going through treatments a little bit too quickly, and may sort of limit treatment options ultimately. So we really need the data to support that says that, we should be using this to guide how we treat cancer. And it may be that at some point we have that data, but we're not quite there yet. So definitely something you can talk about with your oncologist, but if you're being told that it doesn't apply to you, then at least you'll have a little bit of a sense of what the reasoning is, why we're not using it fully in prime time yet. So with that said, thank you so much to Sharsheret for having me here today. These are just a couple pictures from lots of different breast cancer events from just this month alone. This is what my daughter wore on the first day of Breast Cancer Awareness Month, and this was not on purpose. This was just, I think it's in her DNA. So thank you so much for having me.
Thank you so much. You took a took a very complicated topic and were able to simplify it to a certain extent for us. So thank you.
I
Okay.
tried.
It's not easy, and especially with what we've given you in terms of time. So thank you for that. Luckily, we have Q&A available. Our next presenter is Dr. Isabel Choi. She is the clinical director and director of research at the New York Proton Center. Her research focus is on improving outcomes, reducing toxicities, and improving radiotherapy treatment delivery for breast malignancies. She's also an assistant member of the radiation oncology at Memorial Sloan Kettering Cancer Center, where she is a member of the breast service. Dr. Choi is chair of the Physician Advisory Committee of the National Association for Proton Therapy, the chair of the Proton Collaborative Group Breast Committee, and the chair of the American Radium Society Breast Appropriate Use Criteria Committee. As you might be able to tell, tonight she will be speaking about proton therapy. Thank you so much, Dr. Choi.
Thank you so much for that introduction. I'm pulling up my slides now. Are you able to see me?
Yes, we see. Yes, we see
I mean,
them
sorry,
exactly the way
my
they should.
slides. Yes, perfect. Well, thank you so much, first of all, to Sharsheret and the organizers and Melissa for having me. It's really an honor to be alongside these other wonderful speakers and in this forum. So I'm really grateful for this opportunity. Tonight, I'll be speaking on improving the landscape of radiotherapy for breast cancer with advanced radiation modalities and specifically proton therapy. I have no conflicts of interest. Briefly, I'll talk about breast cancer background epidemiology. I'm going to fly through some of that because I think that this group probably knows a lot about that already. Then I'll talk a little bit about breast radiation and why we even use radiation for breast cancer treatment generally. Then I'll talk about what is proton therapy and how we think through selecting the right patients for proton therapy. Of course, the scope of breast cancer is, is the most commonly diagnosed non-cutaneous cancer in U.S. women, accounting for nearly 1/3 of all new cancer diagnoses in women and 1 in 8 women, which is kind of a staggering statistic, is going to be affected by breast cancer in their lifetime. We also know that in the past number of decades, the incidence of breast cancer is slowly on the rise, and there's a lot of reasons why this might be the case, including increased detection with mammography screening that's more ubiquitously used, increased excess body weight, more use of menopausal hormones, and changes in our overall reproductive patterns. So both lifestyle, environmental, and other rationale for this. But in some good news, over the last several decades, we've also seen an improvement in breast cancer mortality. That's decreased by 38% up until 2014. And overall, across stages, 5 years survival is quite good compared with other disease sites at about 90%. And this is likely due to improvements across multimodality therapy, including more targeted systemic therapy, as you just heard from Dr. Zimmerman, increased breast cancer screening awareness, better risk stratification. And for radiation, we have just more modern radiation techniques and treatment guidelines have just become more sophisticated in our delivery of radiotherapy. So then why do we have to give radiation for breast cancer? I get this question actually quite commonly from my patients, and it makes a lot of sense. Most of the time they come to me after they've already had surgery, so they've gotten the gross tumor out. They've oftentimes had systemic therapy or plan to get systemic therapy. So, after surgery, after chemo, the expectation is the cancer is all gone. And my answer is absolutely yes. That is the expectation and the hope. But what we know is that even for early stage breast cancer, we see really excellent survival. Part of the reason why we do is because we do add radiation in the setting of breast conserving therapy, which means lumpectomy instead of mastectomy in combination with radiation. And some of these are dense slides with data, but I'm going to sum them up. And so essentially, for early stage breast cancer, what we know is that even with our best surgeries, even with hormonal therapies, some targeted therapies, by adding the radiation, we're able to reduce the risk of recurrence and decrease the risk of cancer death, And so what that kind of equates to is about 1 breast cancer death avoided by year 15 for every 4 recurrences avoided by year 10. So what the expectation is that while we think we got everything, quote, out, there could be still microscopic residual tumor cells that radiotherapy is really necessary for it to kind of mop up. And DCIS, which is pre-invasive cancer of a ductal type, is kind of the same idea there. By adding the radiation, we're able to reduce the risk of the invasive recurrences. So when we deliver radiation for early breast cancer, what are we really targeting? There's primarily 2 approaches. The first is to treat the whole breast, and you can see that this is an axial slice through the thorax, and you can see that the whole breast is being treated here with radiation in the kind of green shading. And then we also treat with partial breast irradiation, which is just treating the basically lumpectomy cavity or where the surgery took place. And that's for kind of our very good risk earliest stage patients that are potential candidates for partial breast irradiation. Then looking at more advanced breast cancer, so node positive, more high risk features. The reason why we add radiation there after even mastectomy, after a lot of systemic therapy, chemotherapy, is because we know by adding the radiation to the breast or chest wall and the regional nodes, we're able to significantly reduce the risk of a local regional recurrence and improve overall survival. And this has held true over multiple large randomized historic trials. And then moving that into more modern trials with more systemic therapy and even lower risk patients, we again see that there is an improvement in breast cancer mortality and breast cancer recurrence with the addition of radiation therapy. When we treat more locally advanced patients, we're treating a bigger area, not just the breast anymore, not just the partial breast anymore, but also now including the regional lymph node basins. And so here you can see the breast is being treated like for early stage, but then now we're also including the internal mammary chain, which is a thin strip of lymph nodes that sits just to the side of the breast tissue, the supraclavicular region that sits above the collarbone, and also the upper axilla. So essentially half the chest, just a bigger area that needs to be targeted for more advanced disease. So that kind of sets the stage for why we even think about radiation in the treatment of breast cancer, is to reduce local regional recurrence risk and to improve survival. So then how can we deliver radiation therapy? Traditionally, we gave it with what's called photon therapy. This goes by a lot of different names: traditional radiation, standard, conventional X-ray radiation. All of them kind of mean the same thing. It means it's being delivered with the photon particle, which is a small non-charged particle. It can be delivered with a few different techniques, varying sophistication: 3D conformal radiation, IMRT, intensity modulated radiation, VMAT, volumetric modulated arc therapy. We really like our acronyms in radiation oncology. So basically the way that photons deliver dose, these small non-charged particles, you can see here the depth dose curve. So essentially the photon particle, or the X-ray, will enter the body, have a maximum dose pretty close to the entrance of the body, and then slowly exit the body. And as it's decreasing in energy, it's depositing extra dose to some of the tissue before and after, so anterior and distal to the area that's being targeted. Next, proton therapy, which I'm going to be focusing on tonight, is a different type of external beam particle. Proton particles are different from photons insofar as that they are heavier and they're positively charged. So these 2 different properties mean that they have different physical properties in how they deliver dose in the body. So this is in the dotted line, this is native proton beam, and then in the solid blue line, this is a spread out Bragg peak proton beam. So essentially it enters the body, then kind of peaks towards the end of its range at something called a Bragg peak, after which it really quickly decreases in energy and has a very rapid distal dose fall off. So you can see that a lot of the anterior and distal normal tissues, or the healthy tissues, are really being spared from a lot of this unnecessary radiation dose. And that's kind of depicted also in the cartoon below. So I think this audience is national audience and not just New York audience, but for those who are in New York, where can we find protons in New York? At the New York Proton Center, it's the first and only proton center in New York State, and it's a very long partnership between our 3 academic hospital partners, Memorial Sloan Kettering, Montefiore, and Mount Sinai. You can see that NYPC is kind of located centrally to our 3 hospital partners. We treated our first patient about 5 years ago. But nationally, there are now 44 proton centers in the country that are treating patients, which is a vast increase since even whenever I started, 10, 15 years ago, when there was really only 6 or 7 still in the country. So most NCI designated cancer centers now have proton therapy or are getting proton therapy, recognizing the value of protons across disease sites and for a number of our patients. So it's becoming slowly more accessible. So what does proton therapy look like for a patient? This is probably the most dramatic example, craniospinal radiation in a pediatric patient who has a CNS or brain tumor being treated to the whole brain and to the whole spine. This is a patient being treated with protons, same patient being treated with traditional radiation. And essentially what you can see is all of the anterior thoracic and abdominal structures, the heart, the lungs, the bowel, the GU tract, all being exposed less to excess radiation dose when treated with proton therapy. And you can see kind of the subtraction of the excess dose here. And so this is particularly important, of course, in our pediatric population, where protons really kind of got their start, recognizing the importance of normal tissue sparing and still developing organs for a pediatric population. And so clinical benefits like reducing secondary malignancies and reducing late toxicities for them. But for breast cancer, what does that look like? So this is a patient with left breast cancer being treated comprehensively. You can see that compared with the photon plan, the proton plan is better able to spare the contralateral breast, the underlying heart, the lungs, the posterior soft tissue from excess radiation dose. And that's really, I think, the value of proton therapy and the ability to spare unnecessary long-term toxicity of breast radiotherapy by avoiding unnecessary extra radiation dose to all those organs, and potentially with opportunities to better cover the areas that need to be covered. And we know that radiation, unfortunately, can have some long-term toxicity. We know that based on a number of older trials where there is an increased risk of cardiac and pulmonary morbidity. This is just a very often cited study looking at the rate of major cardiovascular events for patients receiving breast radiotherapy. And you can see that there is a linear increase of 7.4% for every increased gray and mean dose to the heart, and that this risk is the greatest in the first 5 to 10 years after receiving the breast radiation, so quite soon thereafter. And so any ability to mitigate even small amounts of dose to the heart can potentially be really beneficial for our patients in reducing these cardiac events. And then the reduction in secondary malignancy with the use of proton therapy has also been demonstrated in some larger studies. And as you just heard, and as I'm sure many are aware, we also know that radiation is not given in a vacuum, but is more often given in combination with systemic therapies like chemotherapy, hormonal therapy, or HER2 therapy. And each of these can have potential impacts on those same structures, the heart and the lungs. And so anything that we can do on the radiation side to reduce any further damage to those organs can be of value. The use of proton therapy across the country is quickly rising, as you can see in the line in the orange. And how do I choose patients for proton therapy? It's not my early stage breast cancer patients where the target is pretty small. A number of our patients are still probably going to benefit from protons, especially if they have like a left-sided medial tumor. But in general, for partial breast irradiation and for whole breast irradiation, so for my early stage patients, I generally don't even bring up proton therapy, because with our more modern and sophisticated photon techniques, we're able to pretty nicely spare the heart in most cases, outside of cases of very challenging anatomy like a scaphoid chest, where we would give excess dose to lungs and on the left side to the heart if we didn't use a proton plan like we're using here. There are trials looking at the potential benefits and impacts of cardiovascular events with proton therapy. This is the RADCOMP trial that finally finished accruing spring of this year, but we won't have answers, unfortunately, from this trial for another 10 years. So a little bit of time to wait there. Other patients who really would benefit are patients with bilateral disease and the really difficult situation of breast reirradiation. So, I said that, across breast cancer, we're now able to achieve quite high cure rates, disease control rates, but in the unlucky circumstance, which we do sometimes see, just given the number of patients who are unfortunately impacted by breast cancer, we do see failures from time to time. And in these cases, sometimes a repeat course of radiation is necessary in order to prevent the tumor from coming back yet again, which we know that risk is extraordinarily high in a recurrent situation. But, with a second course of radiation, there is definitely the potential for significant toxicities. And by using proton therapy and being able to avoid high doses of some of those overlapping organs, hopefully we're able to mitigate some of those toxicities to some degree. Other patients, I'll quickly go through those with a germline mutation predisposing them to secondary malignancy like Li-Fraumeni, BRCA. Those with limited range of motion, or really young population could potentially really benefit from the dose-sparing of proton therapy. And these are just some of the indications that I've been speaking about just in list format and kind of our thought algorithm about how to select patients for proton therapy. It looks like a long list, but it's actually a pretty small subgroup of patients. We treat far less than 5% of all of our breast cancer patients at Memorial with proton therapy. So it's just really select patients who we think would have a disproportionate benefit from using this technology. So in conclusion, proton therapy may benefit some of our breast cancer patients who need radiation. We definitely individualize care based on all the patient characteristics, including some logistical factors to consider, like is proton therapy reasonably accessible, et cetera. And we're continuing to collect additional data from ongoing future clinical trials, other research that we're doing to establish who will most benefit from proton therapy to reduce toxicity and improve outcomes for our breast cancer patients. So thank you, and I'm happy to take questions at the end.
Thank you so much. I think this was likely new information for a lot of us and may actually provide opportunity for some of us. Okay, our last speaker tonight is Dr. Michelle Goldsamler. She is a board-certified reproductive endocrinologist, an infertility specialist, and an obstetrician and gynecologist. She has clinical expertise in both reproductive endocrinology as well as all aspects of fertility treatment, such as IUI, IVF, as well as preventative and medically indicated fertility preservation. She cares for patients both in the Melville and Lake Success locations of RMA of New York, Long Island. Tonight, Dr. Goldsamler is presenting on what is known as PGTM. Thank you for getting this all lined up, and let's go.
I'm so happy to be here with everybody. We're going to switch gears a little bit. I'm probably a little bit of a different approach than kind of what we've heard about in terms of cancer care from our last two excellent speakers. And so I just wanted to first start by introducing what an REI is. So I'm a reproductive endocrinologist and fertility doc. We do full spectrum infertility care for patients or couples or families trying to build their families, including evaluation and treatment, including if they need third-party reproduction like donor egg, donor embryo, or need someone to carry a pregnancy for them, a gestational carrier. We do fertility preservation. We do egg freezing, embryo freezing, which can apply to some of our population here today. We also deal with endocrine issues related to reproduction, PCOS, primary ovarian insufficiency, which used to be called premature ovarian failure or menopause, including surgical menopause for women who've had their ovaries removed for a variety of reasons, and recurrent pregnancy loss. So the question is why is an REI coming and speaking to you guys in this particular setting? And the reason I'm here is because there is some concern for some of our patient population. We know that cancer can affect women at all ages, men at all ages. Hereditary breast and ovarian cancer and other hereditary cancer syndromes sometimes tend to affect some patients at younger ages. And often there's an overlap with the reproductive years, especially for women that have not thought about, are thinking about, or in the future want to think about building their families. There are fertility concerns that they have, whether they have their own personal diagnosis of malignancy, they have a family history of malignancy. And so that's where we can help as an REI. We can kind of help talk about some of the things that we can do to try to assist whether you're ready to build your family or interested in the future. And also to answer that question about, is there anything I can do to not pass that predisposition on to the next generation? And so that's really where we're going to focus on today. And so obviously I can definitely talk about egg freezing. We could talk about embryo freezing. These are ways to preserve fertility before treatment or before needing surgery or other kind of techniques. But what we're really going to focus on today is actually genetic testing of embryos and the ability to kind of look for these changes in genes at the embryo stage before you get pregnant, before you're building your family. And so what is genetic testing of embryos? In the world of REI, we call that pre-implantation genetic testing, or PGT. Like you heard from all of our colleagues, we use a lot of abbreviations in medicine, but PGT, pre-implantation genetic testing, is a general term for any kind of genetic testing of embryos. And there's obviously subcategories of that. There's PGT-A, which is a generalized test that we do for chromosome number to look for aneuploidy or abnormal chromosome number that can happen spontaneously. Just egg and sperm, when they combine, do not combine appropriately. That's type of testing we offer to anyone undergoing fertility treatment. There's specific testing if there's a rearrangement in the chromosome, something called PGT-SR. And what we're really going to focus on today is PGT-M, which is genetic testing for a specific gene. Some of you may have heard this previously be called PGD, or pre-implantation genetic diagnosis. The new term is PGT-M. And what PGT-M is pre-implantation genetic testing for a monogenetic disorder. Again, this is testing of an embryo before you get pregnant. It's there to hopefully find unaffected embryos that are not affected by a particular mutation seen in the genome, to try to prevent passing on that predisposition for hereditary cancer or other inherited disorders. And so PGT-M, again, a monogenic disorder, is that there is a specific change in the gene that is responsible for causing that pathology or that inherited disorder, like BRCA1 and 2. But there are other things that also can cause change in the genome that can also increase that risk of disease. Those are something that we're not going to discuss today. Those are things like recessive disorders can do that as well. But we're really going to focus kind of on that hereditary cancer syndrome testing for a particular gene that increases that predisposition towards malignancy. And so some people come to see me knowing that they have that predisposition, whether they have a personal history of cancer or whether they have a family history of malignancy and therefore want to get that testing done, or know someone in their family who has that increased hereditary risk. There are patients that come and see me for fertility reasons and actually don't even know that this risk exists. And I'm the one who actually elicits that family history of malignancy in the family. And I say, hey, your mom had breast cancer and your grandmother had something with her ovaries and she doesn't know, and you have a first cousin who may have breast cancer. Let's kind of delve into this a little bit further. And then lo and behold, there is kind of a cancer gene that's running in that family. And so when we have that recognition that there is something in the gene, it is a genetic mutation within that family, we can do pre-implantation genetic testing for that particular gene of embryos to try to find embryos that are not affected by that condition. At this point, we aren't able to change that gene, but definitely that is an area of research that's a hot topic and definitely slowly kind of gaining a little bit of traction in some parts of the world. We do not have CRISPR-Cas9 gene editing at the embryo stage at this point, or for cancer, but definitely that is something that we should kind of keep an eye on over the next couple of years. And so how do I do PGT-M? Well, in order to do testing of embryos, I need embryos. I need to be able to have an embryo outside the body in order to do that testing, which means that unfortunately it does require in vitro fertilization, IVF. And so I'm going to walk you through that process just to kind of give you guys a flavor of what does it mean to do this? What does it mean to embark on this kind of testing? And so the first step is to talk to your REI. You have that initial consult. There's some initial testing that we do in the office. We then undergo the IVF process, and then we actually test the embryos itself after we're able to create those embryos. And so from the lab side, what's actually happening with that PGT-M testing? And so what happens in the genetics lab end is they actually create a customized test called a probe, which actually looks at your specific mutation that you have in your family and creates a customized test to mimic that mutation and look for it within the embryos. And so that requires us to have your genetic testing. Sometimes we actually look at family members to see if they also have the same mutation. So we can actually be sure that what we're looking for in the embryo is what's causing the disease increase within that family group. And so when the genetics lab has a request for PGT-M, they do a case review. They collect their own family history. They let us know if they recommend parental testing. Sometimes we have sibling testing. Sometimes we have children testing. Sometimes we're not able to get any additional testing and we're still able to do PGT-M of embryos, but definitely is something that we look at on the PGT-M lab side. And then that generation of that probe, that customized test, used to take 2 to 3 months to actually create that customized test and have it be validated. Now there's actually fast track for some of this testing, which only takes about 4 weeks. So it's really kind of streamlined the process recently, which is excellent, which means that we can get started on treatment while that's occurring in the background at the genetics lab side. Patients will then undergo an IVF cycle so that we're able to obtain the embryos and biopsy them. Those embryos do get frozen for us while we're waiting for those results. And then obviously, once those results are back, we can make some determinations about our next steps. And so that's the genetics lab side. When we get to the REI consult, I just kind of want to walk you through what you're going to experience on the other end. And so the initial consult with us in the office is actually pretty extensive. So I take an hour to sit with new patients because I do a full history. We do a physical exam. Sometimes we even do an ultrasound at that visit. And that includes full personal history, family history, especially that genetic family history as well, and partner history. And so it's pretty, it's definitely a nice lengthy conversation that you have with the REI. And then there's a lot of information that we give back to you and kind of walk you through this process. But after that initial consultation, there is some initial evaluation that we do. When we're talking about fertility testing, there's other pieces of the picture that play a role, like the uterus and the fallopian tubes. But when we're really talking about testing of embryos, our focus here is on the ovary and the eggs in the ovary and the ability to grow a group of eggs, extract that group of eggs, and to create embryos. And so, not to overwhelm you with this slide, but for our women who come into the office, we do a set of testing to look at the ovaries. It's called ovarian reserve testing. It's ultrasound and blood work to take a look at the egg count within the ovaries to first of all see and give estimates about how many eggs do I think I can grow if I was doing a cycle of IVF, but also to determine your dosing of medication, how you may respond to fertility treatment. When you're not actively trying to get pregnant, we kind of keep that uterine testing on hold, but it's something to look at in the future. There is some blood work that we need, and there's actually some additional genetic testing that we recommend for couples undergoing this process, because we want to make sure if we're already going through this process and testing embryos, we want to make sure there's nothing else that we need to also be looking at and testing those embryos for. The PGT-M test is a test that looks for one specific mutation. And so it's not looking at everything else in that embryo. It's not looking at any other disease unless we're specifying another specific disease. For our male partners, they also undergo a workup with us. I do need a semen analysis to make sure the sperm is normal. We do blood work for them, and again, genetic testing for them as well. And we actually have our own set of genetic counselors. They are reproductive genetic counselors who focus specifically on the genetic testing of embryos. And we're going to discuss that a little bit more. And then when some couples come to see me, we also want to make sure that this process is going to be safe for them medically. And so there's some coordination of care that happens between us, the oncologist, the surgeon, the radiation oncologist. We're all kind of working together to make sure we figure out the appropriate timing of this treatment and make sure that it's safe medically for you guys to undergo this process. And so just to give you a sense, again, that ovarian reserve testing is a vaginal ultrasound that looks at the ovaries. We are able to actually see what's called follicles, these little dark circles. These are fluid-filled spaces that have microscopic eggs. We can actually count them and see how many potential eggs are there for that month. And we can kind of get a sense of, well, if I give you fertility medications, how many of those eggs may potentially grow. We use this ultrasound in combination with blood work to kind of give a sense, again, of that ovarian reserve or egg potential. And again, just to remind everyone, just kind of clarify, the genetic counseling that we have is reproductive genetics. This is not cancer genetic counseling. This is really your liaison between the clinical REI and the IVF process and the genetics lab that is going to be doing the embryo testing. Our reproductive genetic counselors first can confirm that the mutation that you have is something that we can test for in embryos, and then also helps coordinate care in case we do need external testing or family member testing. Now I know we're kind of running out of time, and so I'm going to just very quickly walk you guys through an IVF cycle. IVF cycles can take as little as 2 weeks to up to 6 to 8 weeks. It basically starts with your period. You have 2 weeks where you take injectable medications and grow a group of eggs. We monitor how those eggs are growing with ultrasound and blood work. At the end of those 2 weeks or a little bit sooner, we undergo a procedure which is called an egg retrieval, where we remove that group of eggs from the body. We mix the egg and sperm together to make embryos. Those embryos grow and develop for at least 5 days of development. And at that stage, they're ready to be biopsied for genetic testing, and they get frozen that same day. Okay, those embryos will remain frozen and can remain frozen indefinitely until you're ready to use them, be it 5 years, 10 years, 20 years, 25 years from now. As long as you are medically healthy to be pregnant, we can get you pregnant with those embryos that are frozen. And so just, again, that stimulation, that growing egg phase takes about 2 weeks. The medications are injections. The ultrasound, as you can see here, this is what the stage that the ovaries start at. And then those follicles get quite large. We're able to kind of follow the growth of those follicles. Again, I can't see a microscopic egg there. I'm seeing the fluid around the egg, the follicle grow and develop, but there is calculations about, are these eggs mature? Are they ready to be extracted based on their size, based on hormone levels? And we move forward for that egg retrieval, that egg extraction, which happens in our office. It's an office-based procedure. It's done with IV sedation anesthesia. You are asleep, but you're comfortable for that procedure. You do not have an endotracheal tube down your throat. You are breathing on your own. Takes about 15 to 20 minutes. It's all done through the vagina. It's a transvaginal procedure. There are no cuts or incisions on the belly, and it's ultrasound guided. So the same ultrasound that we use to look at the follicles, that same ultrasound is used to guide a needle into those fluid-filled spaces and extract the eggs. Once the eggs are removed later that day, we mix the egg and sperm together with a process called ICSI, where we take a single sperm and inject it inside the egg. This makes sure that it's only one sperm and one egg DNA that are combining, so that when we do genetic testing, we know that we have a clean, accurate sample for testing. And then once those egg and sperm are combined, those embryos develop for 5 days of development. And at that stage, they are called a blastocyst, which is ready for implantation. So if you weren't doing testing and trying to get pregnant, that's the stage where we would put the embryo back inside the body. But if we're doing genetic testing of the embryos, this is a stage where we biopsy the embryo and then freeze it. Now I'm going to attempt to show you, let's hope it works, This hopefully should be a video showing that 5 days of development of an embryo. This is something called an embryoscope, which is a camera attached to an incubator. This is not my video. This is Vitriolife, which is the company that develops the embryoscope. It's going to show you cell division, show that embryo going from a 2-cell to 4 cells to 8-cell structure to a ball of cells, and then eventually that blastocyst. Let's hope that it works. There we go. Okay, so we see the initial embryo here. We see that is that 2-cell stage. That's on day 1 after fertilization. It divides and becomes a 4-cell stage. And then that divides again and becomes 8 cells. That's day 3 of development. Those cells then start to divide. You get a whole ball of cells called a morula. And then those cells, that's day 4. And then those cells continue to divide and actually start to separate into 2 pieces. There's a group of cells that clump together called the inner cell mass. Those are the cells that eventually become the baby. And then there's a collection of cells on the outside which become the placenta. And so if you see here, there's the collection of cells that become the baby, the inner cell mass. And then the cells along the outside are the cells that become the placenta here. Now let's see if I can continue. There we go. And so the inner cell mass, again, cells that become the baby, and then the outer cells, the cells that become the placenta, these cells are the ones that we biopsy for genetic testing. We don't disrupt the cells that become the baby because that can interfere with normal, regular development, but we are actually biopsying, and it's safe to biopsy the cells that become the placenta. And those cells get sent to a genetics lab. And then again, they use that specialized customized test, those probes, to actually identify if the cells that we biopsied contain the mutation or not. We get a report back in about 4 weeks, give or take, and then we review that with you along with our genetic counselor, letting you know how we found embryos that are unaffected by this disorder. Those embryos, again, remain frozen until we're ready to use them. I do want to let you know that some people don't find unaffected embryos during that 1 cycle of IVF. Some patients do need to go through more than 1 cycle in order to have whatever desired cohort of embryos they want. But this at least allows us to identify, of the embryos that you're making, do we have unaffected embryos? Can we have those in storage for you for whatever your family building plans are in the future? Now, these embryos are put back 1 at a time in the future, and those future children will be at baseline risk for these cancer syndromes. They are back in the general population pool. They do not have a BRCA mutation. And then we're not saying that there's no risk of malignancy, but it's kind of at that baseline population risk, which is what our goal is during this process. And so I know that that was quite a bit, and I hope I didn't go over too much. But I do just want to thank you guys for giving me the opportunity to speak here. Thank you, Sharsheret, for the amazing work that you do for our population. And of course, if anyone has any questions, I'm happy to take them at any point.
Wow. Thank you so much. First of all, I'm sure you couldn't see it because you were talking. Lots of people really liked that video. They hadn't seen anything like it before. Okay, we're going to do a little flip-flop here. For people who cannot stay on, I'm going to conclude right now, but then we're going to go back to Q&A for people who can stay on, and we will still do the Embrace breakout. That'll happen just a couple minutes later and still end no later than 9:30. So first of all, please let me thank Drs. Choi, Goldsamler, and Zimmerman for their insights and passions. Thank you for making yourselves available to educate our community on the newer technology we are beginning to see find its way into practices. It's so exciting that there was so much to share tonight. Thank you again to our summit sponsors, AstraZeneca, Daiichi Sankyo, Merck, Novartis, Pfizer, City of Hope, AZI, Northwell Health Cancer Institute, and RMA New York, Long Island, and of course to Sherry Helfand-Weiner on her support for tonight's webinar, along with Northwell and RMA. Please take a moment to fill out a brief evaluation survey that is going into our chat box now, a link to it. What's great is you can fill that out and not be kicked off the webinar. You can still listen. It'll take you just a couple of moments to fill out. Of course, the webinar continues, we hope through the middle of November, we hope you'll join us this coming Wednesday for October 30th for Sharsheret in the Kitchen with recipe developer Erin Grunstein of Erin Eats, and on Wednesday, November 6th, as we close this year's summit with the Sharsheret Book Club featuring Rabbi Sharon Brous, author of the national bestseller, The Amen Effect. Links to learn more and to register are going into the chat right now. Okay, let's go back to Q&A, which means that I am going to bring our speakers back on to share the spotlight, and we're gonna highlight just a couple of questions that came through. I am having a hard time finding Dr. Goldsamler. Dr. Goldsamler, are you still on?
I pinned myself. I don't know if that's helpful.
That's not helpful.
I'm here.
Q&A, Bonnie, can you help get her on the screen? Oh, wait, that's everybody. Hold on. I've got to remove that spotlight because we were trying to spotlight everybody. You know what? I'm going to ask one of my colleagues to get us to add spotlights as opposed to replace while we start the Q&A. Okay. First of all, a question that came in many times beforehand and many times tonight. Can proton therapy be used when radiation has been administered during a previous cancer diagnosis?
Great question. So re-irradiation is actually one of my several research focuses. And the reason why is because it hasn't been done a lot in our field to date. And the reason why is because we didn't have access to protons, right? We had photons primarily historically. And as you saw, it kind of spills dose everywhere. And when you need to give radiation a second time to all those same tissues, it can be very toxic. And so most practitioners, most radiation oncologists kind of either didn't give radiation at all or gave suboptimal doses that we knew weren't going to salvage their cancer at all, just in an effort to spare excess toxicities. With protons, we can now offer re-irradiation, a second course of radiation, better than we could in the past because we now have the ability to spare the heart from getting a second course of radiation, the lungs, the brachial plexus. However, that's with a caveat that the areas that have to be treated a second time that are part of the target, breast, the chest wall, the ribs, they're part of the target. They have to get a second course of radiation. So it can still come with some toxicities, but in order to achieve second cure, sometimes it's kind of a balancing the risks and the benefits, and it's necessary to control the cancer, because with any recurrence of breast cancer, there's a very high it's a high risk situation. They tend to be very aggressive in nature, and if you don't control at that time, then kind of the cat's out of the bag.
Thank you for that. Again, this question came in during the registration process, but a couple of people did also ask it in tonight's chat box. So somebody asked, why is it that when a tumor for the first time goes to testing, they're not automatically tested for every known biomarker or things like that? And why is it that we need to perform this again later on? And then similarly, and I'm guessing this might be your answer, or I could be completely off, but the other question was, how frequently are new biomarkers discovered, and when does it make sense to retest the original tissue?
Sure. So I think I can speak to that a little bit. So one of the reasons we don't test automatically in, let's say we're talking about advanced breast cancer, is because depending on the type of cancer, it may not affect the first line therapy. So if it's not going to change how we do our first line treatment, we're not going to test at that point. We may test if the tumor starts to progress. And the reason we want to test later is because we're actually looking for new mutations which may develop as a result of first-line treatment. So something like the ESR1 mutation wouldn't develop until after you were treated with an aromatase inhibitor. So it's a constantly evolving kind of situation where, as the medical oncologist, we want to kind of be looking out for when's the right time to do the testing where it will actually change our management, and the tumor can change over time. In terms of how often biomarkers develop, I mean, we're not talking about a daily thing. So, maybe we have 5 biomarkers that have developed that we know about over the course of the past decade. But the testing that we do can test for like hundreds of different markers at the same time. So once you do that testing once, it's kind of done and you don't need to keep repeating it over and over again. And if something new is discovered, then they would add that into the panel and then test patients moving forward.
Got it. Thank you so much. Okay, Dr. Goldsamler, we got an interesting question. Someone shares that both her sister and herself have gone through IVF fertility treatments over the past number of years, and both of them independently have been diagnosed with breast cancer very recently, despite no genetic predisposition. So the question is, do IVF and other fertility things, whether they're done so PGTM can be done or whether they're done because of primary infertility, what are the updated cancer risks for doing that kind of thing?
So it's a frequent question that I get actually from a lot of my patients about, in general, taking hormones. Is hormones going to kind of increase my risk of breast and ovarian cancer? And actually, the vast majority of the data that we see targeting specifically artificial reproductive technologies, IVF, does not show an increased risk in either worsening breast cancer that already exists. And so I do this fertility preservation for breast cancer patients who are trying to preserve fertility before chemotherapy. And so it does not worsen their prognosis of their current breast cancer or increase the risk of a second site, a second primary breast cancer for these patients. Interestingly, there's actually a recent trial that, part of it may still be ongoing. I think is the positive trial, which is about taking a break in endocrine therapy for receptor positive patients to get pregnant in order to achieve a pregnancy. And so actually there's some data in that trial itself that over 40% of the participants in that trial needed fertility services. They needed something like IVF in order to conceive because they've already, either because they were a little bit older when they were ready to conceive, or actually as a result of their cancer treatment. And despite having 40% of this population needing IVF, there's actually no change in difference in risk of recurrence, whether you took a break and or needed IVF to conceive versus continuing on your endocrine therapy. And so that's actually really reassuring that this process, first of all, taking a break from treatment in order to achieve your family goals, but also specifically needing fertility treatment with a personal history of a cancer diagnosis is really reassuring.
Wow. Okay, thank you. There were a lot of questions. I wish we had more time. Maybe we'll repeat this webinar sometime in the next year or so, and there are even more cutting edge technologies we can talk about. Before we move on to the Embrace breakout room, I just want to remind everybody that Sharsheret is here for you. We provide emotional support, mental health counseling, other programs designed to help you navigate through a cancer experience, both starting with before a diagnosis and genetic information all the way through long-term survivorship. All are customized, confidential, and completely free. I just saw our contact information up in the chat box. We're going to put the SurveyMonkey link up one more time. Again, you can do it and still join the Embrace program. Thank you to Dr. Choi, to Dr. Goldsamler for joining us tonight, and thank you to Dr. Zimmerman for helping us and staying on with our Embrace community. Thank you and have a wonderful evening. Good night.